Hey guys, Coach Royce here again in part 2 of my video series on FAI, or femoral acetabular impingement, also known to people who don't know anatomy as a pinchy hip. So, in my last video, you guys discovered what pinchy hip is, generally speaking. And again, like I said in the last video, usually 90% of the time or more, it is literally this simple. You have a dysfunctional rotator cuff. Next, I'm going to help you guys self-diagnose. If it is not the rotator cuff, I can tell you exactly what to look for, and you can continue to either solve the problem or figure out what the source of the problem is and address it, whatever that may be. So here goes. Again, glute minimus, right side of the hip. We're looking at the portion of the glute minimus that acts as the hip flexor and internal rotator. Again, all athletic movements demand this exact thing. So, here we go. Are you ready? I'm excited. Again, I'm going to tell you guys the reason I know all this information is because I might be one of the only people on the planet who's ever experienced every single one of these injuries. Lucky me. However, what I'm doing right now is putting together a video for you guys so that I can educate you on how to make this go away, how to make pinchy hip go away. You can get back to your training, how to make the pain go away, and how to make sure it never comes back again. And if you have an underlying problem, an actual injury, I can help you diagnose it and fix it. So, here goes. All right, I'm gonna go right down the list here, help you guys self-diagnose this issue. So, okay, say you're doing a lot of squatting in your programming, and one day you wake up and you go into squat, and suddenly you've got like this little bit of instability, like you got a little hip shift to one side at the bottom of the squat as you come up. Or you have this kind of searing, pinching pain right in the front, right? Well, for the people that are not educated in things like physical therapy and anatomy, usually people think that the location of the pain is exactly where the problem is, but usually it is not. I'll give you an example. Whenever somebody has impingement in the shoulder, they feel pain down the side of the arm because it's pinching the rotator cuff. When you have a pinch, by the way, the pinch is up top. If you have a pinch in the front of your hip, it is because you have an imbalance in your hip and your hip socket is unable to glide freely into hip flexion, so it is pinching in the front. There needs to be this, I'm going to bring this closer to the camera again, there needs to be a pull from the posterior aspect of the ilium in order to glide the hip into hip flexion without it jamming in the front. Without that posterior glide, you won't have it. So, starting from the first one. First thing you get a pinchy hip. I have no idea what's going on, but I can't squat as much and I can't squat as often because it's hurting and it's hindering my stability. You go to the doctor says, go to physical therapy. Let me guess, you go to physical therapy, they have you do a bunch of clamshells and some single leg stuff. Kind of, sort of helps a little bit, but doesn't really fully solve the problem. Is that about right? Well, this is your general femoral acetabular impingement, FAI, diagnosis. Basically what this means is they don't know what's wrong with you. I'm going to tell you. They're going to give you a series of tests, including tests for stability, a test called the Fitzgerald, where they jam you into internal rotation and hip flexion, just like we just talked about. They're going to palpate. They're going to touch the glute medius. If you actually have an issue, you're going to feel pain in the majority of these things. If you don't have an issue and you just have a gummed up rotator cuff of the hip, you're going to get a little bit of pain in internal rotation hip flexion, which you already knew because you felt that, and you're going to get pain on palpation. You are not, however, going to suffer from lower back pain, most likely. Sometimes you do. Severe, significant low back pain, pain on the medial side of the knee, the inside of the knee from serious lack of stability. You're not going to have foot pain in general. People get plantar fasciitis because the arch starts to collapse. Let's see here. Referred pain down the leg, generally speaking, if it's just a gummed up rotator cuff, you're not going to get referred pain down the leg. So, does it hurt to touch? Does it hurt to jam into internal rotation and hip flexion? But you can stand on one leg with relative ease. You don't have knee pain. You don't have foot pain. You don't have lower back pain. It's just hindering your athletic movements. Guess what? You get a glued up up glute minimus. You need to address it directly where I pointed out before. Posterior aspect of the glute minimus origin. Next, you have probably the second most common diagnosis in these hip issues is a torn labrum. And personally, when I had my first hip pinch experience, I did some self-diagnosing online and I came to the conclusion that I had a torn labrum because I fit a lot of the tests for that. Well, here's how you can tell if you have a torn labrum or don't have one. Again, Fitzgerald test, internal rotation hip flexion. They're going to lie you down on a bench and jam you into hip flexion, internal rotation. You're going to have pain there, probably a little bit. You're going to have, if it's a torn labrum, you will not have pain when they push on your glute because you don't have an inflamed or a gummed up glute. Most likely, again, most likely internal rotation, hip flexion, pain, palpation, no pain. You're not going to have a loss of abduction strength. You may have pain, abduction, you lie on your side, raise your leg up. If you have trouble raising your leg up or if the doctor's trying to resist your leg and you're having trouble with the strength, it's a different issue. It's not a torn labrum. A torn labrum will not affect your strength. It will only give you joint pain in that specific position. That's how you know if it's a torn labrum. You will have referred pain. Don't ask me why. First time I tore my labrum, I felt pain down my leg. I still don't know why, but you get referred pain with a torn labrum. Let's see. You won't have lower back pain because there's not an instability issue. It's inside the joint. It's not a stability issue. You will not get medial knee pain. Again, stability. You will not get foot pain. Stability. It's the joint. That's how you can tell. So just with these two columns here and the information I just gave you, you can take this to your surgeon or your doctor and probably correct them with their misdiagnosis. Next up, you have a lower back issue. In most cases, I would say almost all of the cases I've ever seen, it's never been a disc issue. However, I need to address this. This has a column on its own. If you have a bulging disc or a herniated disc, it's going to give you pain down your legs and it is going to affect, generally speaking, your stability in your hips, pelvis, and knees. Just a little bit. It is not, however, going to give you pain when you touch your glute medius and minimus. Probably maybe a little bit from general inflammation on the area, but if you drive your fingers into that muscle and you have a torn glute medius minimus or a gummed up rotator cuff, it'll just about put you to your knees. If you have a herniated disc or a bulging disc, not really as much pain there, if any at all. That's how you can tell if it's a bulging disc. The bulging disc, generally speaking, will cause you to have referred pain down both of your legs. Unless it's bulging to one side, then you'll have pain all the way down the leg, and it will go all the way down to your calf or even your foot. Other signs of a disc issue might be, let's see, referred pain. You're going to have lower back pain if you have a bulging disc. That's inevitable. Primarily because most of them are posterior bulges, meaning they're pushed to the back side. The disc is being pushed backwards. If you go into an arch or an anterior tilt with a bulging disc or a herniated disc, that will cause you more pain because you are, in a sense, squishing the disc back in. You're compressing the disc in a positive way most of the time. You're compressing it back into position. That's actually why if you go to physical therapy for bulging discs, they're going to make you do these things on the floor called cobras, which is pushing you into extension, compressing the disc back in. They make you do a bazillion reps. Yes, so here's the irony. Here's something I want to talk about in another video, something called casting. When the body senses an injury and then begins to modify your movement patterns and tighten up certain muscles to protect you from that pain. But here's the catch. Casting is never a positive thing. When you have a posterior bulge, your body is going to cast you by tucking your pelvis, bringing your rib cage down, and making you round more, which is going to exacerbate your disc bulge or your disc herniation. This is pretty much the case for every casting scenario throughout the entire body. I could give you a list of them. You always, most of the time, have to go into a place of discomfort to make the injury better. Moving on. Hey guys, thank you very much for watching my educational video on hip dysfunction and FAI. I hope that you found this information valuable. Please share. Let's get this out into the general population and into the medical community. I really think that we are not good enough at solving hip dysfunction yet, and I really truly believe that this is why. This is also a call for help for me personally, as I have ruptured the glute minimus muscle, the rotator cuff of the hip, off of the anterior facet of the greater trochanter. And I have seen so far 12 surgeons over the last 4 years that both A, think that this tear is not causing the dysfunction that I have, and B, have provided me with basically no solution, no real cure to reattach this tendon. I will show you what it is very quickly. We have confirmed this via vertical MRI and via ultrasound, but here it is. This is the right hip. The glute minimus muscle, as shown earlier. This is what is referred to as the long head, attaching at the posterior ilium to the anterior facet to act on internal rotation. I believe that it is ruptured off just like this, and I believe the procedure will require going in with a camera to locate the end of the tendon and pull it back through and reattach it to the anterior facet. Again, guys, please share this video if you found it helpful and if you want to help me out. Thanks again for watching. We'll see you guys in the next video.